Good morning. This is Ibrahim Aldoss from City of Hope in Duarte, California. I would like to thank the organizer for inviting me to present on immune therapy and frontline treatment for adult B-cell ALL. These are my disclosures. So age at the time of ALL diagnosis is prognostic, and we can see that survivals decrease as patient age increase. And if we look at the SEERS database, which is a registry database in the United States, outcomes of ALL in older patients were extremely poor and hasn't changed significantly over the recent years. This is the same database where we can see that older patients can be defined as 55 and above, only represent 22% of all newly diagnosed cases of ALL, but they contribute to more than half of all deaths related to ALL. And looking at older patients enrolled in clinical trials, which usually these are more fit patients to meet the eligibility criteria, their outcomes remain poor, and overall survival is in the range of 20% or less. So why older patients with ALL, they do poorly? There are different reasons. Part of it, they tolerate chemotherapy poorly. They have high rate of induction mortality and death in remission when they treated with chemotherapy induction, consolidation. And it's difficult to maintain the treatment schedule in older patients with ALL as they get the condition between cycles, and they tend to develop prolonged cytopenia that usually delay subsequent treatments. And importantly, important drugs like asparaginase, full dose vincristine, high dose steroid, high dose methotrexate cannot be administered safely in older patients with ALL. So the treatment usually inadequate. On top of that, they tend to have high risk disease biology. Older patients more frequently have pH positive ALL, complex karyotype, low hypodiploidy, KMT2A rearrangement, IKZF deletion, and TP53 mutations. And all of these predict usually low response to chemotherapy and high risk of relapse. Even the entity of pH-like ALL, which is a chemo-resistant subtype of B-cell ALL, is not uncommon in older patients. This is a large multi-center study included older patients with B-cell ALL. You can see that pH-like ALL represent up to a quarter of all cases of B-cell ALL. Adding to that, usually older patients, they tend to have more comorbidities. There are more medications that can interfere with chemotherapy administration, as well as the psychosocial support limitation will become difficult to bring them frequently for treatment, either with chemotherapy, even post-transplant care as well. So older studies, they try to intensify the chemotherapy backbone for older patients to achieve better outcomes in terms of cure, have failed in older patients. And this is one example. This is the BITHEMA ALL96 study, where investigators induce older patients with ALL with 5-drug regimen. And the study was actually amended early because in the first 10 patients, 7 actually died during induction as a result of toxicity. So asparaginase and Cytoxan were actually removed from induction, and this led to lower induction mortality and higher CR rate. But with kind of less intense chemotherapy, the risk of relapse remain high. And even with low intensity chemotherapy, older patients continue to experience death in remission afterward. And this led to kind of low overall survival in these patients. So immune therapy like blinatumomab and intuzumab have shown promise in relapse refractory B-cell ALL, including older patients with B-cell ALL. And typical factors that predict chemoresistance, it doesn't appear to impact the response to these agents, such as poor cytogenetic, increasing the patient age. And also, the toxicity of these drugs are unique and different than chemotherapy and appear to be more tolerable and not age-dependent. So both drugs, blinatumomab and intuzumab, led to superior response rate as well as overall survival compared to physician choice of salvage therapy in relapsed refractory B-cell ALL. Focusing on blinatumomab, so you can see here age is not a predictor for response. Older and younger patients, they respond the same. Now, what predicts response to blinatumomab is the disease burden before treatment. And there is more interest to treat patients with blinatumomab when they have lower disease burden because you can see the response is significantly different. And in pooled analysis from prospective studies comparing outcomes of blinatumomab in relapsed refractory patients, if they are younger or older than, they're younger or older, you can see that the response, the MRD response, the relapse-free survival, and overall survival were comparable for younger and older adults with relapsed refractory B-cell ALL. And you can see here also that the toxicity overall is comparable with the exception of grade 3 neurotoxicity, which is more common in older patients compared to younger patients. So blinatumomab is safe and active drug in older patients with relapsed refractory ALL. Age itself does not influence response or survival, and blinatumomab has a favorable safety profile. And the promising activity has been seen in both relapsed refractory patients as well as MRD positive disease. And there is actually more motivation to give it in low disease burden, including MRD, because we see higher response as well as the durability of remission is longer. This is from the BLAST study where patients treated with relapsed refractory MRD positive disease with blinatumomab, and the orange curve is patient didn't receive consolidation with allogeneic stem cell transplant. And you can see at 5 years, you still have maybe a third of the patients remain in remission. So it's potentially curative treatment when you give it in low disease burden. Plus, when you give it in low disease burden, you tend to see lower toxicity. Intuzumab also has shown activity in younger and older patients, and age itself did not influence response or progression-free survival. Now, in contrast to blinatumomab, intuzumab is active in both high disease burden and low disease burden, so it can serve better as a cytoreduction treatment before you give blinatumomab. So, moving to immune therapy in frontline treatment for older adults with Ph-negative B-cell ALL. So with the data I present, there is an interest to integrating blinatumomab and intuzumab early in the treatment paradigm for older adults with ALL, part of it to improve the safety as they have lower toxicity than chemotherapy and potentially can reduce the induction mortality, the death and remission. And with the activity we see with these agents in relapsed refractory setting, they can overcome the suboptimal response with chemotherapy. We can produce higher CR rate, MRD response, and possibly durability of remission. And because they have a better safety profile, it can maintain the physical fitness of older patients for subsequent, more curative consolidative therapy like transplant or CAR T-cell therapy. So there are different studies looking at the question of frontline blinatumomab and intuzumab in older patients. So this is the SWOG 1318, one of the earlier studies. And in the study, older patients defined 65 and above receive induction treatment with blinatumomab for 1 or 2 cycles, followed by consolidation with blinatumomab for 3 cycles, and followed by pump maintenance. You can notice here that because these are untreated patients, no cytoreduction was given. The median bone marrow blast was high, 87%. So these patients, they have high disease burden. Sorry for that. Even with that, the CR rate was 66%, and including MRD negativity in the majority of responders. There were no early death, and overall survival and disease-free survival were kind of looking more favorable compared to historical control. They were 37% at 3 years. Another study, which is actively enrolling, is the Golden Gate study. And in this study, this is a phase 3 study comparing blinatumomab with low-dose chemotherapy versus standard of care that can be either hyper-CVAD or GML regimen in older patients with newly diagnosed ALL. Now, this is the experimental arm of the study, where patients actually receive low-dose intensity chemotherapy a week before starting blinatumomab induction. And this is followed by blinatumomab if the patient responds, then consolidations with 4 cycles, including 2 methotrexate and 2 blinatumomab, then maintenance pump and blinatumomab. There was a safety run-in phase done in the first 10 patients. And you can see here that these 10 patients, the median age was 69. And the majority, they have high disease burden. And even with that, with the introduction of low-dose cytoreduction chemotherapy, this led to response in all these 10 patients, including MRD response in 9 out of 10 patients. And now the phase 3 study is actively enrolling patients. There's also studies including intuzumab as a frontline therapy in older patients with ALL. So this is the EWAL-ENO study, where 2 cycles of induction intuzumab given with low-dose chemotherapy, followed by consolidations and pump maintenance. The study enrolled 131 patients, and it shows high CR rate, 90% after induction 2, and the majority achieve MRD negative. Now, encouragingly, the treatment-related mortality was low, only 3%. And these outcomes, considering that the median age was 68 and the majority, they have high-risk genetics. And these are the survival curves on short follow-up. A similar study is the GMAIL Initial 1 trial that also enrolled older patients with Ph-negative B-cell ALL, where they received 3 cycles of induction with intuzumab, the first one with dexamethasone, the second and third one only with IT chemo, followed by consolidation, reinduction, and maintenance. In this study, all patients achieved CR, and the MRD response was high, 74%, and there was no early death within the first 6 months, and these are the survival curves for these patients. Now, another approach was taken by MD Anderson group, where they actually combined both intuzumab and blinatumomab in older patients with B-cell ALL. Patients receive the mini CVD with intuzumab as initial cycles, followed by consolidation with blina, then maintenance with pump and blinatumomab. This is one of the earlier reports and showing that in patients treated with this regimen, the overall response was 98% and overall MRD response was 96%. However, it became clear that not all older patients are the same. Those in their 60s, they tend to do better than in their 70s. And this is mainly related because you're having more death in remission in patients in their 70s, including this novel regimen. This led the investigator to amend the protocol to eliminate chemotherapy in older patients to reduce the rate of death in remission. This is another presentation, another update from the mini CVD plus intuzumab plus minus blinatumomab presented in the EHA 2022. And in addition to older age, patient didn't do well. Patient with actually poorer cytogenetic, they didn't seem to do well as well. However, the outcomes for patients in their 60s and without poorer cytogenetic was very encouraging, 69% at 5 years. Another exciting study that was just presented this year is the Alliance 041703. This is a chemo-free regimen for older patients with Ph-negative B-cell ALL, where patients receive intuzumab induction, followed by blinatumomab consolidation, no maintenance, no chemotherapy. And the median age was 71, and you can see the CR rate was as high as 96%, and at least early survival data appear encouraging. At City of Hope, we actually took a different approach. We asked the question, well, CD19 CAR T-cell therapy has a role as a frontline therapy in older patients with ALL. Since these patients, they don't do well with CAR T-cells in the relapse refractory setting when there is an active disease, we're trying to introduce it as a definitive consolidation therapy in CR1. So patients achieve CR1 with any initial frontline therapy. They will be eligible if they're 55 and above, and there's no immediate plan for transplant. The idea is if you give it in patient in remission, the toxicity is low, So that will be ideal for these patients, more likely to experience severe toxicity with CAR. At the same time, there's data indicate when you give CAR T cells in patient remission, the durability of remission is longer, and potentially it can be a curative treatment. Now, moving to younger adults with Ph-negative B-cell ALL. Similar to older adults, there are different studies. They're looking at the same question: can we introduce blinatumomab, intuzumab during induction consolidation in these patients? And the idea that younger patients treated with pediatric-inspired regimen, they still have more toxicity compared to children, and the rate of relapse is higher. Can we improve on this? And you can see different groups, they ask the same questions, and the CR rate is high, MRD negativity was very encouraging, and at least in short follow-up, the survival rates appear very encouraging. One of the important studies that was presented recently is the ECOG 1910 study. And in this study, patients between 30 and 70 years old with newly diagnosed Ph-negative B-cell ALL receive induction, intensification, and if they achieve MRD negativity, they get randomized to the backbone consolidation plus maintenance, or the same backbone chemotherapy consolidation with 4 cycles of blinatumomab. So the study shows survival benefits with adding blinatumomab during consolidation MRD negative CR1 patients, as well as improvement in relapse-free survival. And it will likely change our standard of care, how we treat these patients. So as expected, you have lower risk of dying from leukemia, but what's surprising was that also death and remission was lower in patients randomized to blinatumomab. And potentially this is by giving blinatumomab between chemo cycles, it will reduce the risk of having complication from continuous chemotherapy treatment and reduce the risk of sepsis. Now, surprisingly, most of the benefit was seen in younger patients, but not in older patients randomized to blinatumomab, which is, we still don't know why. I think we need to see the paper to kind of understand why this is the case. Another randomized study using intuzumab as a frontline therapy in younger patients with B-cell ALL is the Alliance 041501, where the patients receive the backbone CLGB 10403 regimen, but randomized to either the standard consolidation versus 2 cycles of consolidation with intuzumab after induction, in addition to the same backbone chemotherapy. Unfortunately, the study was suspended a couple of years ago due to unacceptable toxicity in the investigational arm, and appeared it was more related to sepsis later in the course of consolidation. But we're still waiting for more results to see if the introduction of intuzumab was superior in terms of MRD response, and potentially on longer follow-up, we may see improved outcomes. What about Philadelphia chromosome positive ALL? Is there any role for immune therapy? So this is data from MD Anderson looking at their Ph positive ALL patients, where they show the improvement over the years in Ph positive ALL by the introduction of tyrosine kinase inhibitors, by the introduction of ponatinib, third generation tyrosine kinase inhibitor, and more recently immune therapy as part of the frontline therapy of Ph positive ALL. So it became very clear after the introduction of tyrosine kinase inhibitor that intensifying the chemotherapy backbone in Ph positive ALL doesn't improve outcomes. This is the graph 2005 study where they compare vincristine, prednisone, imatinib induction to hyper-CVAD BART-A plus imatinib. And in this study, the actual induction mortality was higher in the more intense regimen and led to lower CR rates compared to lower intensity chemotherapy. But overall outcomes in terms of molecular response, overall survival were comparable between both arms. Now, since chemotherapy doesn't work, as blinatumomab showing really encouraging outcomes in relapse refractory B-cell ALL as well as Ph-negative B-cell ALL, the DELBA study enrolled patients with Ph positive ALL, adults with Ph positive ALL, to be treated with induction with the dasatinib and steroid for 3 months. And after 3 months, they continued the dasatinib and they received 2 to 5 cycles of blinatumomab concurrently. So the study shows that the combination was safe. And after the first cycle of blinatumomab, the rate of molecular response was almost double. And this can be prognostic in pH positive ALL. And we can see for this chemotherapy-free regimen, the overall survival, disease-free survival outcomes were encouraging. Similar study was also conducted by the SWOG. This is the 1318 study where dasatinib and prednisone given for 3 months, then blinatumomab was introduced with dasatinib. But this study enrolled older patients, 65 and above, and outcomes were encouraging as well. Now, as ponatinib, third-generation tyrosine kinase inhibitor that has actually activity in many of the resistant mutations we see with dasatinib, investigators at MD Anderson combined ponatinib with blinatumomab as a frontline therapy in pH-positive ALL. And this study, blinatumomab was used during induction as well, not like the DLP and the SWOG, where it was used after induction. And this study, you can see the overall response was very encouraging, 96%, and the majority achieved complete molecular response. And these are the survival curves, very flat early on. So it's very encouraging outcomes. And what's encouraging about this study that the majority of patients didn't go through allogeneic stem cell transplant. So it's potentially a curative treatment, but we need a longer follow-up. With that, I conclude that the integration of immune therapy in frontline treatment for adults with B-cell ALL has shown early encouraging results, both younger and older patients, pH negative and pH positive. And it's likely that our standard of care is changing, especially with the phase 3 ECOG 1910 study that shows benefit of blinatumomab consolidation even in patients achieve MRD negative CR with chemotherapy induction. However, there still efforts are ongoing to optimize the timing and the sequencing of these agents and that to reduce the treatment of to reduce treatment toxicities. Thank you for listening. Thank you.